Hello, my name is Ben Carroll, and I'll be discussing the chapter on skull lesions in children, authored by Dr. Mason Shiflett and myself, both of the University of Mississippi Medical Center, Department of Neurosurgery in Jackson, Mississippi. Objectives for this chapter are first to discuss the clinical, radiographic, and pathologic characteristics of the major skull lesions that present in childhood and adolescence, and secondly, to outline both conservative and surgical treatment strategies and clinical outcomes for patients with pediatric skull lesions. For suggested readings and citations, I'll refer you to the print and electronic versions of the text. Scalp and skull masses tend to present to a variety of different specialties, most often with abnormal cosmetic appearance or discovery of a symptomatic mass by a child or a child's parents. Because they present to a variety of different specialties, studies of incidence and presenting symptoms tend to vary according to what these particular specialties like to focus on. So it's difficult sometimes to pin down exactly the percentage of incidence of a particular skull lesion or the particularly most common presenting symptom. Let's start with inclusion cysts. These include dermoids and epidermoids. They comprise just a little over half of pediatric scalp and skull lesions together. Epidermoids are a little less frequent, usually 3 to 5% of skull lesions. Both of these are likely caused by misdirected epithelial tissue that embeds down into the skull, either during embryonic development or possibly due to trauma, more rarely. Most of these present as rubbery, immobile, painless lesions anywhere from sub-centimeter to 5 centimeters, and most of these present before the age of 5. They largely involve the outer table, but may erode down and invade the dura. Dermoids, they can be located anywhere on the scalp, but dermoids tend to frequent the midline, usually stereotypically at the site of the bregma or the anterior fontanelle. Occasionally there are dermal sinus tracts associated with dermoids that extend deep to the skull and invade the dura. Epidermoids are more frequently found off midline, usually along sutures, most commonly the corona. In clinical assessment of these lesions, a good way to test whether or not there is dural invasion or extension below the skull is to perform a Valsalva maneuver and check for swelling of the cyst. In terms of radiographic and pathologic analysis of these lesions, more traditionally plain x-rays were ordered. These showed a lucent center with some bony erosion, usually a dip in the bony surface with a hypersclerotic rim. More commonly now we're using CT and MRI. CT shows a homogeneously hypodense lesion with often some calcifications that you can see in dermoids. MRI is the most common radiographic way to analyze these. Dermoids tend to have a heterogeneous signal intensity, sometimes with contrast enhancing walls. Dermoids, by contrast, are hyperintense on DWI characteristically, and sometimes have a more fluid-like intensity. In terms of microscope, epidermoids have a characteristic layer of keratin-producing epithelium, and then on gross examination you can see the contents are normally white, cheesy colored debris. Dermoids, by contrast, have a little bit more complexity to their walls, including not just keratin-producing epithelium, but also cutaneous adnexal cells. And their debris, the typical contents, can include not just keratin debris, but also sebaceous and sweat secretions produced by exocrine glands. So here, an MRI of a fairly typical dermoid cyst presenting in a 7-year-old female. You can see a little contrast enhancement to the rim of the cyst and its typical location over the anterior fontanelle or the bregma, just over the superior sagittal sinus there, which can complicate a resection if you do have to drill down beneath the inner cortex, looking for the full extent of these lesions. And then a couple of microscope slides. You see on the left an epidermoid cyst with a thick layer of keratin-producing epithelium. On the right, you see a similar keratin-producing epithelium, although more complex cell layers in a dermoid cyst, and then also some glandular structures. And then also with a dermoid cyst, you see a characteristic more corrugated pattern to the cyst wall that you don't see in an epidermoid cyst. The most highly recommended treatment option for epidermoids and dermoids is early surgical resection. This is for two reasons. One, these lesions can enlarge due to glandular secretion, so these lesions can become larger, eventually making resection less cosmetically favorable if the lesion is larger. Secondly, there is rare incidence in the literature of malignant transformation with these cysts, so it behooves you to take these out early. Early resection, if you get the whole thing, is most often curative. However, if you get an incomplete resection, you can get recurrence. And then if you have lesions that are on the forehead or around the orbit, that would create a cosmetically less favorable approach. You can, some surgeons will, and that's provided you don't have significant bony erosion or extension below the skull or into the dura, then some surgeons will use an endoscope to take these out. The surgical procedure itself, you generally plan a curvilinear incision around the lesion, usually posterior to it, to avoid incising directly into the cyst. That's because if you don't resect these in block, a ruptured cyst, in other words, can contaminate the field and can cause a granulomatous reaction. In the course of your dissection, you may find a small fibrous or neurovascular pedicle arising from the suture that may necessitate curettage. Cauterization often is effective, or drilling down in the bone to get to the full extent of the cyst. If there's a bony defect that's large after you've had to drill some, you may consider reconstruction with split thickness cranial bone grafting. And then if you create sharp or scalloped bony margins with drilling, then you of course would want to smooth these down with a drill or a curette. So one example of a recent dermoid cyst that we resected, it's the 7-year-old that you previously saw MRIs for. Here is the curvilinear incision around the cyst itself, leaving a wide enough incision to get a good dissection so that you can avoid rupturing the cyst. Here's dissection itself. The dermal layers above the cyst, and then you'll see taking the pericranium, getting a wide resection around the cyst with attached pericranium and pulling that away from the bone. You can see here the neurovascular pedicle that we found at the bottom of this cyst. So with this particular cyst, not only curettage and used cautery to try to get that cyst resected, but also had to drill a little bit to find the full extent of the vascular pedicle. And these cysts can sometimes take on, it's worth noting, these cysts can sometimes take on a dumbbell configuration. So you can see there can be a significant portion of this cyst below the skull invading the dura, which you would normally see on MRI and would know whether or not you were more likely to have to drill around a pedicle like this to get to the rest of the cyst. And then finally, the coup de grace piece de resistance of dermoid cyst or epidermoid cyst resection is the gross examination of the keratin content, the cheesy debris on the back table. Moving on, Langerhans cell histiocytosis. These lesions account for 7 to 10% of reported skull lesions in children. So LCH represents a spectrum of disease that presents in 3 typologies. The first is one location, single system disease. So these are the classic eosinophilic granulomas that you find in one location. A solitary bone lesion, usually asymptomatic, just a small raised deformity. Although they can be tender, they can cause headaches, and you can rarely have extradural hemorrhage associated with these. Typically present ages 5 to 15 with a male predominance. But in addition to the single locus, single system disease, there are also multifocal single system disease and disseminated multi-system disease. With the multifocal single system disease, generally the bone is the most common single system involved, and the skull is the most common location for bony lesions. So classically, these are known as Hans-Schüller-Christian disease and Letter-Sive disease, and because of the multifocality of lesions, these typically present before the age of 2, as opposed to the unifocal single-system disease that presents a little bit later on in life. Multi-system disease can disseminate into the CNS and viscera, leading to lesions in a wide variety of systems: skin lesions, pulmonary infiltrates, hepatosplenomegaly, pancytopenia, lymphadenopathy. And then lesions of the pituitary stalk can lead to DI. You can get orbital invasion that leads to diplopia and exophthalmos. And there are skull lesions that can cause cranial nerve deficits, and even parenchymal brain infiltration can lead to deficits associated with the locations that infiltration occurs. For instance, you can also get spinal lesions that can be associated with scoliosis or pathologic fractures. In terms of radiographic and histologic analysis of these lesions, they're characterized histologically by Langerhans cells, which are immunoreactive for CD1A, S100, and CD207, that is Langerhans transmembrane proteins. The traditionally top tennis racket-shaped Birbeck granules that you would see in the cytoplasm on electron microscopy are no longer necessary for diagnosis, as they have 100% concordance with that Langerhans transmembrane protein. On films, traditionally skull x-rays are obtained. They show an osteolytic lesion with unequal involvement of the outer and inner tables, hedging to one side or another, typically involving a hyperostotic rim. CT, however, is the best way to see these lesions. Shows an expansile lesion. MRI can be obtained as well. That typically shows an enhancing lesion, but you can also see a hemorrhagic core. Or, as we've discussed before, you can see extradural hemorrhages with these lesions. A nuclear bone scan can be obtained, particularly if you are worried about multifocality, because dark lesions will show up. It's an easy way to identify if you're dealing with a unifocal single system or multifocal single system or even multi-system disease. Despite occasional location over venous sinuses, typically venous sinus invasion, vascular invasion, is not seen with these lesions. Now, once one of the more recent updates with Langerhans cell histiocytosis is that it was once thought to be perhaps just an inflammatory response, but they are now considered to be of neoplastic origin because of the discovery of mutually exclusive activating somite gene mutations at BRAF and MAP2K1 locations that occur in just over half and just under a quarter percentage of patients, respectively. Here you see a couple of lesions, or the same lesion on two different imaging modalities, an X-ray AP on the left, and then an axial CT on the right. You can see some calcifications, an expansile lesion there interrupting the bony structure. In terms of treatment options for Langerhans cell histiocytosis, for multisystem disseminated disease and single system disease, either unifocal or multifocal, that involves lesions of the skull base, odontoid, or facial bones, which are termed CNS risk lesions. For these versions of the disease, systemic therapy is generally warranted, and that consists of steroids and vinblastine. But management of single-site, single-system cranial vault Langerhans lesions has traditionally involved a wide surgical resection to normal bone margins with curettage. This is particularly for lesions that cause intense pain or unfavorable cosmetic appearance or functional disabilities. Generally, a wide surgical resection was recommended. However, with the unifocal disease, while a limited number of these lesions will progress to multifocal disease, many of these unifocal lesions will resolve per the natural history without aggressive surgical treatment within 1 year's time. So there's a question now about how quickly and how aggressively we should try to resect these lesions. performing a wide surgical resection with extensive drilling may not be warranted in a lesion that can resolve within a year's time. So simple curettage of the lesion is a less invasive option than wide, extensive drilling. And also, if you've got an asymptomatic, only mildly painful, isolated lesion, observation is a reasonable alternative for a lesion that recurs, for a lesion that grows. An intralesional steroid injection is a possibility, and then a simple core biopsy to confirm that you are in fact dealing with histiocytosis is also a possibility. Because these lesions can often resolve, the European Histiocyte Society has recommended avoiding a full resection of a large lesion. Their recommendation is greater than 5 centimeters because such a large resection can lead to prolonged healing, permanent bony defects, and a lesion that may resolve within a year or more. Moving on, fibrous dysplasia. It's a benign fibroosseous lesion of immature mesenchymal cells that typically involves the long bones, the rib, and the skull. These lesions typically present with painless osseous expansion and facial asymmetry. There are two types. The monostotic form is more prevalent at just under 3/4 of cases, and this usually presents by age 30, as opposed to the polyostotic variant, which typically presents in early childhood, presumably to the multifocality of the lesions. Again, these lesions usually involve the long bones, rib, and skull, and when there's craniofacial involvement, the most common involvement we see is the ethmoid bones, but you can also see sphenoid, frontal, maxillary, and temporal bones. There's also a more systemic version of the disease, a syndromic version, McCune-Albright disease, which is a clinical diagnosis made when you have 2 out of the following 3. That's polyostotic fibrous dysplasia, an endocrinopathy, which is often precocious puberty, and cafe au lait spots. Evaluation of fibrous dysplasia. Typically a thin cut CT is what you would want to order. It shows an expansile bony remodeling that can be with or without sclerotic or lytic changes. The classic ground glass appearance is really only apparent in about a third of cases. MRI can be helpful if you're looking for cranial nerve compression. So histologically, these lesions form when cancellous bone is replaced with fibrous tissue, and also when collagen is infiltrated by immature woven bone. So on slides, fibrous dysplasia lesions have a proliferating fibroblastic stroma and thickened osteoid-rich trabecula composed of delicate woven bone that eventually takes on what's known as a classic Chinese figure formation. Genetically, the mutation is on chromosome 20 at the GNAS1 locus. So films here, you see an axial CT on the left, and then a lateral view X-ray of a 9-year-old male with a left frontal focus of fibrous dysplasia. You can see some of the bony remodeling, the expansion and the fibrous tissue with some hyposclerotic bone, but also some lytic components. And then here's another patient with more extensive fibrous dysplasia. You see involvement of the anterior skull base, ethmoid orbit, and extensively the frontal bone with a heterogeneous appearance. Treatment options for fibrous dysplasia. So, with notable exceptions, monostotic fibrous dysplasia enters quiescence by the end of puberty, will stop growing. But growth can be seen later on, on average, in the polyostotic variant. So you'll want to determine the number of your lesions in order to figure out how these lesions will change over time. Asymptomatic lesions can be managed conservatively with the caveat that sequela can occur. These typically pain or fractures. Medically, treatment has typically been with alendronate, although clinically levels of pain or disability there's no significant effect shown yet, just an effect on bone resorption markers and improved bone mineral density. There is rare malignant transformation. Over half of those cases are associated with radiation, which is now strictly contraindicated. There's also been work done into treatment with denosumab, which has shown some promise, but there are serious concerns over life-threatening rebound hypercalcemia that can occur, as well as the potential osteonecrotic side effects of the lifelong use of this drug to control fibrous dysplasia lesions. Surgical treatment. There are large lesions that cannot be entirely resected without significant comorbidity and are often not amenable to reconstruction. But approaches have spanned all the way from contouring procedures to total resection with reconstruction. That's largely determined by the size and the location of the lesion. Surgical resection for large lesions should probably wait until after puberty, again because they're higher. These again single-focus lesions, monostotic type, tend to go into quiescence after puberty. So, and you can get a higher rate of recurrence if you resect them prior to puberty. If there's orbital apex involvement, that can lead to proptosis, diplopia, distorted facies. Optic nerve encasement is common, but blindness is infrequent. Care needs to be taken in resecting these lesions. And then with McCune-Albright syndrome specifically, it does not appear to reach quiescence at all after puberty. So what may be required is periodic debulking procedures versus large, risky resections that are highly comorbid. So you do these periodic debulking procedures, you may preserve some cosmesis, but at the same time limit morbidity and preserve options for future reconstruction. Juvenile ossifying fibromas. These are typically benign, painless bony lesions that are often identified because of facial or skull deformity, but can be associated with nasal obstruction, proptosis, visual deficits. These can be also rapidly growing lesions. There are two types. Trabecular type, often found in the mandible and maxilla, which usually presents between ages 5 to 15. And then there's the cymomatoid type as well, which involves the paranasal sinuses, orbit, and calvarium more commonly. These typically present later on in teens to adulthood. Trabecular types on CT tend to show up as a predominantly radiolucent lesion with a well-defined thin corticated margin, and sometimes you can see scattered calcifications. It tends to be a fibrous connective tissue contained by a surrounding bone. There can be a hemorrhagic component or cyst formation to these lesions, and that can sometimes signal the development of aneurysmal bone cysts associated with these lesions. On microscopic slides, you see a highly cellular osteoid with large irregular osteocytes. The cymomatous JPOFs on CT show typically a thick ground glass outer mantle with central radiolucency, and these can be confusing, look like fibrous dysplasia. Typically the ways to tell the difference compared to fibrous dysplasia, the JPOFs have a little bit more radio-opaque borders, and fibrous dysplasia looks a little bit more heterogeneous over the breadth of the lesion. Cymomas you would see on microscopic slides on pathologic analysis are concentric laminated ossicles containing osteocytes. Treatment for these lesions, they should be removed surgically with curette or drill. Either type can become aggressive, and we see high recurrence rates as late as 2 decades after resection. So these lesions need to be resected and then followed yearly with imaging. Here you see in an uncharacteristic location, actually a JTOF, trabecular variant here. You can see a thin rim of bone around fibrous tissue, and then you can see post-resection with a split thickness graft over the anterior skull base. This child did well. Also here a JPOF, again a thin rim of bone with some fibrous tissue in the middle. And finally, lipomas. These are clinically benign lesions with a propensity to show up to hide in long bone metaphyses. Of all bony lesions, lipomas represent 0.1%, and of all lipomas, only about 4% are found in the skull. However, with increased use of advanced imaging modalities, this 4% estimate may be lower than the true incidence. A lot of these lesions are found in a wide distribution of ages, reported as early as age 3 or as late as age 85, presumably because they are most often clinically benign and incidentally found. CT would show a trabecular resorption with or without bony expansion or fat attenuation, regions of hyperdensity due to fat necrosis and calcification. MRI signal looks very similar to the subcutaneous adipose tissue that you'd see nearby. You can see some fat necrosis as well if you notice variable T1 mixed T2 signal. In the reported cases of calvarial involvement, these lesions are predominantly located near the sphenoid, frontoparietal, and sphenoclival lesions, and they contain usually a very distinct border that signals that they are chronic lesions. If you identify these lesions very carefully, you can prevent an unnecessary surgery, unless they are in an unfavorable location or located where they can cause compressive deficits in the orbit or the sella. These lesions do not need to be resected. Thank you very much.